invite Dr. Ra from South Korea, and we are going to be continuing this critical limb ischemia 1 session with critical limb ischemia 2. Dr. Ra is going to be talking, giving 3 back-to-back talks, and we are going to invite him for the first talk on piercing technique for SFA and BTK calcified lesions. Just to introduce Dr. Ra to the audience, right now we have about 4,800 people watching this across the Southeast Asia and across the world. Dr. Ra is the in charge of cardiovascular center at Korea University Guru Hospital. He's a terrific interventional cardiologist, vascular interventionalist, and structural heart disease expert. And he's got many techniques to new innovative techniques on endovascular side to his credit. And he's under, as a primary PI and a very terrific researcher and a primary PI for many trials. It will be an honor for all of us to have Dr. Ra on board and to listen to him. So Dr. Ra, can we have your first slide on piercing technique for SFA and BTK calcified lesions?
Thank you for your kind introduction. Can you hear me, Dr. Khanna?
Yes, we can hear you, and we can also see your slides.
Okay, we are very significant delayed behind the schedule, so I straight go forward my title of presentation, Piercing Technique, the requested title from the organization. Nothing to disclose. I belonged to many Korean and international society, but I'm in charge of K vascular intervention, Korean society, peripheral intervention, currently serving as a president. We are producing many research and inter-society activity for the vascular intervention. For this kind of focal significant calcium, this external piercing technique for the direct extravascular needle-induced crack is one of very simple, I can say that very cost-effective, cheaper way for the some particular case of balloon uncrossable lesion due to significant encircling calcium or the balloon passage failure case. So I'd like to focus on one simple case in the BTK and the SFA case. Let's see this. Maybe some of you already saw yesterday. This is for the demonstration case. Stumpless ATA, maybe partly some clues are on the mid-island in the proximal TBR. They skip all the course, subintimal tracking, I did the 3-5 system, angioplasty, and exchange it to the 14 system, and then prone the balloon inflation, the entire TBR course. This PTA course did the subintimal after successful angioplasty, exchange it to the 14-wire system, and maximally dilated using this focal, the fluoroscopy, no obvious very dense calcium. However, multiple non-compliant coronary balloon all were unsuccessful to dilate this focal lesion. More than 10 non-compliant balloons were ruptured. So here, clearly you can see that this after balloon angioplasty, this focal undilated lesion is limiting flow to the distal full circulation. At that time, the 3 self-expanding and balloon expandable barometer stents were available in our country. So for the educational purpose, because this is a critical limb ischemia, to show how the BTK focal piercing technique works, I intentionally deployed this BTK stent. You can see that this focal expanded stent, and retrograde puncture technique is required. And instead of micropuncture, we need a forceful needle. This is a 3-5 system, femoral puncture needle, and retrograde the puncture fashion, circumference at least 2 orthogonal view. You need to direct the external needle crack in the encircling fashion. So you can see this unexpanded focal area with time is slowly expanded. So not just focal pricking, you have to completely destroy the unexpanded area. Then easily this non-convalid can expand this unexpanded previous non-dilated area. As we expected, there must be injury, but do not fear about this injury because there's an underlying in the endothelial layer inside. So you have to prolong the inflation 2, 3, up to 5 minutes, then easily hemostasis can be achieved. The prolonged inflation, complete hemostasis, and the distal perfusion, nicely you can achieve. So 3 months later, this very good foot circulation and nice wound healing could be achieved. And this second case is a critical limb ischemia and the multiple risk factors, previous CABG, multivascular patients, and left previous PTA was failed due to heavy calcium. Previous CABG patient, and this patient, you can see the dense calcium in the both SFA, and this previous in other hospital, 2017, SFA wire, even wire crossing was failed due to right SFA calcification. So this time, the peripheral angiography, you can see that this dense calcium in the SFA common femoral bifurcation area. So this focal dense calcium, you can imagine that this is a area need at least endoarterectomy or the hybrid manager to deal with at least the calcium modification using the arthrotomy plus DCB. It's necessary we need to avoid the stenting in this area, joint area. So, however, today's focus is to just make a space in this joint area. So we did a common connector flex 18 wire system under the support of microcatheter, CXI support, and the cross into this joint area, and sequential balloon dilatation with the 18 system to the increase up to the non-compressible balloon with the Mustang balloon up to 6 millimeter. And then you can do sequential balloon dilatation. We made a space here and change it to the 3-5 system. And previous failed data, this is the target of today. Not so focal area, but the dense calcium is the problem. So this mid SFA CTO was not easy to crossing by usual wire. CTO wire, every CTO wire from the 18 system, from the Asahi CTO wire or the Abbott CTO wire, from Connect Asahi series, everything failed. Subintimal tracking, soft thermo 1.5J, and stiff thermo, everything, subintimal calcium neglect strategy, everything failed. So I started retrograde and bidirectional, but you can see this retrograde wiring also, the distal cap was so hard, so bidirectional failed. So what we have done was just something, wire is entered here and the distal, there was a gap, we could not completely do the kissing wiring, and the last result was to the modification by the proximal wire maximally sent to the calcified body, and the subintimal partly inserted, and we did the retrograde puncture and maximally inflate the retrograde balloon here, inserted the little balloon, and the inflated balloon targeted and inserted another re-entry device using the outback device from the CODIS, because originally I wrote the CRM paper in this year regarding this fibre technique. This is the facilitated intravascular ultrasound like balloon assisted reentry, because the pioneer reentry device assisted, we can do the reentry device assisted re-puncture to the balloon. Instead of that, because the Pioneer is not available in Korea, so instead of that, we used this outback catheter and re-puncture to the, because CT wire cannot puncture the balloon, retroid the balloon. So this puncture needle from the outback catheter directly puncture to retroid the balloon, and this wire is entered to the inside of the balloon and snare it out. Puncture here, and the snare the inside of the balloon and outside the snaring, and the externalization was done. And due to this forceful encircling wire, we could deliver the anterior balloon. Then the balloon angioplasty was done. So the proximal stenting was nicely could be done. Illuvia droid stent, and then adjuvant ballooning, and the proximal portion we did turbo hook, and the balloon droid balloon was done. And this is due to the sheath insertion in the distal SFA and the very aggressive manipulation. Despite of this aggressive manage, successful common femoral superior stenting in TCB and the droid stenting in the SFA, but focal is just here some population was not came down, so the swelling becoming evident. So we need to do something. We wanted to do the seal-off by the graft stenting, but due to this residual stenosis, we could not deliver the graft stent. So problem is the graft stent profile is bigger. So only one way, every NC balloon, plan modification, scoring balloon, everything could not dilate this residual focal calcium. So my decision was doing the piercing technique. In the stented portion here, you can see unexpanded focal calcium. So complete destroy of this focal calcium by the multiple retroid puncture fashion. You can see this stent is slowly expanding, similar to previous BTK case. So aggressive puncture, retroid puncture technique, multi-angle, then slowly expanding. So after this, non-compliant balloon, prolonged inflation, then nicely cracked the calcium, then we could deliver the graft stent. This is a Korean SNG stent graft 6 by 40 millimeter, and the adjuvant ballooning, prolonged inflation, then finally nicely sealed off. Then you can see the good distal run-off without perforation. So nicely sealed this perforated site by the focal graft stenting. The BTK perforation was fine. So sometimes this external piercing technique is very useful in undilatable focal calcium. So just femoral puncture is needed, no micropuncture needed. And deeper SFA location, sometimes you need pericardial synthesis set, the bulky SFA muscle. So the lesion location may be safer way is uncompressible area, usually BTK and the distal SFA. So this is focal calcium area, really difficult to expand by the usual conventional device. This is sometimes very useful, as I shown in this case sample. Thank you for your attention.
Thank you, Dr. Rao. That is truly a very innovative technique, and I'm very excited to use it in some of our patients, because many times we get into this trouble and patient has no money, and this probably would work out very well, and you have shown it very very explicitly that it works. I just had a question. Do you also sometimes produce dissections by doing this external needle piercing? Can you dissect the artery?
Yeah, sometimes the dissection can be exaggerated or extensive. However, the main problem is the perforation itself, the injury by the needle can be extensive than my expectation. So sometimes the prolonged balloon inflation itself could not come down, even 5 minutes and 10 minutes. And so some particular case, prolonged inflation in circumferential area, sometimes I inject thrombin and the external outer electrical bandage application, then wait for 5 minutes and 30 minutes, and sometimes nicely sealed off. Some particular case, However, usually the dysfunctioned, in the case, the if you don't give the really too much extensive injury, that will be usually calmed down by the prolonged inflation.
Thank you. And then we move on to your next presentation on hybrid management of popliteal entrapment syndrome. I'd also request Dr. P.C. Gupta to join in as one of the panelists, and Dr. Walid Kadro to continue along with Dr. Ra, Martin Merish, and Dr. Vinay Kumar.